Dr. Catalina, and I'm going to be talking about middle ear infections in children. I see a lot of kids in the office with middle ear infections. In fact, it's the most common cause for pediatric acute visits in the United States. 1 out of 4 children will develop a middle ear infection in their first year of life, and 6 out of 10 children in the first 4 years. A child's anatomy is different than an adult's. The ear anatomy consists of 3 parts: the outer ear, the middle ear, and the inner ear. The outer ear includes the auricle and the ear canal. The middle ear has the eardrum and the middle ear space, and the inner ear has 2 organs that allow us to hear and maintain our balance. There's a tube that connects the middle ear with the throat called the eustachian tube. The eustachian tube in a child is narrower and more horizontal. As the child gets older, the tube gets wider, and it also becomes more steep because as the head grows, the ears rise higher above the throat. A tube that is more narrow and flat is much more likely to get plugged up. When a child develops a cold, inflammation and mucus will plug up the eustachian tube. This will effectively not let air in and out of the middle ear space, and it'll cause fluid to build up in the middle ear. In the fluid, bacteria can grow, causing inflammation and pain, and that is what we call a middle ear infection. Studies have shown a number of things that will increase a child's risk of developing middle ear infections, and some things that decrease the risk. Things that increase the risk are called risk factors, and these include young age. The incidence of a middle ear infection is highest in children under 2. A child exposed to secondhand smoke is 1.7 times more likely to develop a middle ear infection than one who is not. A child with a close relative that has a history of middle ear infections is 2.6 times more likely to develop a middle ear infection than one without that family history. Children who attend a daycare with 4 or more children are 1.4 times more likely to develop middle ear infections than children cared for at home. Children who use pacifiers are 1.2 times more likely to develop a middle ear infection than children who do not. Even though pacifiers slightly increase the risk of developing an ear infection, I'm a big fan of pacifiers because they've been shown to decrease the risk of sudden infant death syndrome, or SIDS, and to decrease the likelihood that the child will be a thumbsucker. However, it is recommended to stop the use of pacifiers at around the age of 2. Native Americans, Alaskan and Canadian Inuit children, and Indigenous Australian and Greenlander children have a higher incidence of severe and recurrent middle ear infections than do children of Caucasian descent. Children with immune suppression, Down syndrome, cleft palate, and allergic rhinitis have a higher risk of developing middle ear infections. There are some things that decrease the risk of a child developing a middle ear infection, and these include breastfeeding. Breastfed babies have less pathological bacteria in their nasopharynx, and breast milk contains antibodies which can be protective. You should always feed your child in an upright position. Children who are given a bottle while laying down have a higher risk of developing a middle ear infection. Lastly, vaccinations are very protective against infections. When I started practicing pediatrics, I would see a lot more children with middle ear infections than I do today. One of the most common bacteria that causes middle ear infections is Streptococcus pneumonia, and children have been receiving a vaccine that protects them against strep pneumonia. The vaccine is so effective that the incidence of acute otitis media in the first year of life has decreased from 60% when I started to practice to 23% today. Yearly flu vaccination and other vaccines that children receive during their regular vaccination schedule are also protective against many infections, some of which can cause middle ear infections. The typical presentation of a child with a middle ear infection is that they start with a cold for a few days, and then they develop a higher fever, increased fussiness, pain, and in an older child they will tell you that their ear hurts. When I evaluate a child for an ear infection, I first look at the outer part of the ear. I'm looking for signs of trauma, redness, or inflammation. I then look at the ear canal to see if there's any swelling of the canal or any purulent discharge that would suggest an otitis externa or swimmer's ear. When I look at the middle ear, the first thing I see is the eardrum. In a child with a healthy eardrum, it will look pearly and flattened or retracted into the middle ear space like this. In a child with a middle ear infection, that eardrum will look red and bulging out into the ear canal like this. The only way to know for certain what the bacteria is that is causing a child's ear infection is to get a sample of the bacteria. This would entail putting a needle through the eardrum, suctioning out some fluid, and sending it to a microbiology lab for culture and identification. We generally don't do this. Instead, doctors make an educated guess of what the bacteria might be. The three most common bacteria that cause middle ear infections are Streptococcus pneumonia, Moraxella catarrhalis, and Haemophilus influenza. In 2013, the American Academy of Pediatrics, together with the American Academy of Family Practice, released updated guidelines for the treatment of ear infections in children 6 months old and older. They recommend in a child with severe or bilateral infection to treat with antibiotics. In a child with milder infection or unilateral infection, consider supportive treatment and pain management and observation. And consider antibiotics after discussion with the parents. In the years that I've been practicing, I've had this discussion with many parents, and I've found that most parents who've been up all night with a child with a fever and ear pain would like to start the child on antibiotics in order to help their infection get better quicker. The 2013 guidelines recommend the first-line medication to be amoxicillin. There are 3 situations where I don't use amoxicillin as my first line. The first is in the child who is allergic. The second is in a child who's been on antibiotics in the preceding month. Or the third is a child who has conjunctivitis in addition to otitis media. This suggests that the bacteria causing their infection is non-typable Haemophilus influenza. Non-typable Haemophilus influenza is often resistant to amoxicillin and needs a stronger antibiotic. Most ear infections will improve on antibiotics. However, occasionally they don't, and they need to be reevaluated and put on a stronger antibiotic. The complications of acute otitis media include a ruptured eardrum, loss of balance, loss of hearing, or an infection that spreads, causing mastoiditis or meningitis. If your child is not improving on their antibiotics, please be sure to contact your medical provider. A child who has had 4 or more ear infections in a 12-month period should be referred to a pediatric ear, nose, and throat doctor for evaluation. The pediatric ear, nose, and throat doctor will review the history, examine the child, and may recommend placement of pressure equalizing tubes or ear tubes. Pressure equalizing tubes are placed in the eardrum and allow air to go in and out of the middle ear space and allow fluid to drain out into the ear canal. They effectively take the place of the eustachian tube and should prevent the accumulation of fluid that leads to middle ear infections. I hope this video has been informational and useful for you. If your child is sick, I encourage you to seek medical attention. If you'd like more information, please visit our website at www.medicalassociatespediatrics.com.